arthritis, and I'm going to address the issue of a patient presenting with fever and the question of differentiating between disease exacerbation from concomitant infection. So we'll just take a look at whether there is a risk of infection in patients with rheumatologic disorders, and if so, why is it so? The types of infections which are common in our context, how to differentiate between disease exacerbation and superimposed infection, the diagnostic workup, and empiric treatment in our setup. So is there a risk of infection in rheumatologic patients, and if so, why is it there? It is well known that many rheumatologic conditions, especially rheumatoid arthritis and even SLE and other vasculitic disorders, are associated with phagocyte dysfunction. And this dysfunction involves not only chemotactic deficiency, but the process of phagocytosis is impaired, and intracellular killing is also impaired. And the classic infections which are associated with phagocytic dysfunction are staphylococcal infections, recurrent infections of Staphylococcus aureus, and other major bacterial pathogens like gram-negative. Nocardial infection is another category of infections which you see in somebody who has phagocytic dysfunction. Then, infections with hyphal fungi are common in individuals with phagocytic dysfunction, like infections with Aspergillus or even Rhizopus. Then complement dysfunction or disorders are also common in vasculitic diseases, and complement deficiency can occur, which may be acquired as an SLE or may be congenital, as you see in patients who have a predisposition to develop SLE. And this complement dysfunction or deficiency predisposes to infections with encapsulated organisms. And the typical example which we see very often is that of severe Neisseria sepsis in somebody who has complement deficiency, or recurrent infections with unusual serotypes of Neisseria meningitidis. Complement system has regulatory effects on B cell function and on cytokine production as well, so the humoral arm of immunity is also affected. There is T cell dysfunction, and signaling abnormalities have been found in various vasculitic disorders, and these in turn lead to dysregulation of B cells. There is decreased IL-2 production, which leads to decreased cytotoxic responses and increased rates of infections. And the infections which are typically associated with T cell dysfunction are Candida infections, or infections with yeast-like fungi, cryptococcal infections, and viral infections like herpes zoster, which can take a disseminated form in someone who has severe suppression of T cell mediated immunity, and reactivation of mycobacterial infection. Risk of infection differs with the type of disease and disease activity, and more than one type of infection may be present concomitantly. Patients with rheumatoid arthritis have a significantly increased risk of infection and increased mortality from infections. Common infections which are seen in patients with rheumatoid arthritis are septic arthritis, chest infections, and infections of skin and soft tissues. Risk of infections requiring hospitalization is generally higher, and oral corticosteroid use is associated with a dose-related increase in risk of infections. Biological disease-modifying agent use is also associated with a slightly increased risk of infection. Infection rates are clearly high with certain disease-modifying agents like cyclophosphamide and azathioprine, which can cause qualitative and quantitative defects in phagocytic cells and even T cells. But there is a controversy whether methotrexate predisposes to greater risk of infection or not. So is there a risk with methotrexate treatment? It has been suggested that any increased risk of infection associated with methotrexate, low-dose methotrexate usage, is offset by improvement in the immunological function overall, and resulting in an overall neutral infection risk. And there have been studies which have actually shown that there is no increased risk of infections in individuals who undergo hip or knee replacements who are on methotrexate. However, not all studies show elevated infection risk in rheumatoid arthritis overall, and there are some studies which have shown no difference in infection risk in RA patients when they compared it with osteoarthritis or fibromyalgia. But probably these differences are due to the differences in study design and not actual. If we move on to other rheumatologic disorders, the risk of infections is high in SLE, and this is higher than that seen in rheumatoid arthritis. Lupus patients who get infections frequently have worse clinical signs. They require longer treatment than non-lupus patients. And bacterial infections of the respiratory tract, urinary tract, septic arthritis, TB, salmonella, shingles, etc. are more common. And the most common fungal infection seen in lupus is with Candida. The risk of infection is high in patients who have increased disease severity and in the presence of comorbid conditions like diabetes, chronic lung disease, alcoholism, and in those who are on corticosteroids. So the risk of major infections in SLE is influenced by treatment, and prednisolone treatment, even at moderate doses, increases the risk, while anti-malarials have been shown to be protective. Let's take a look at the infectious complications of biological therapy. These treatment modalities have revolutionized the treatment of rheumatologic disorders, and it is important to realize that there are degrees of differential susceptibility to infection across rheumatic diseases, and these should be taken in account in weighing the infectious risk of biologics. The majority of infections which develop in someone who is on anti-TNF treatment, the infections are minor and they usually occur within 2 years of starting treatment. Opportunistic infections, including TB, do develop, but they have been reported to be rare. And the incidence of infections decreases with the time on biologic therapy. And it has been suggested that vaccinations should be given to these patients, although live vaccinations should be avoided. So according to the ECR guidelines, tuberculosis screening is mandatory before starting anti-TNF treatment, and this is very, very important in our context because TB is very common in our part of the world, and every effort should be made to exclude presence of latent or even active TB in someone in whom you are contemplating biologic therapy. And patients should be given vaccinations against pneumococcus, influenza, and hepatitis B before embarking on anti-TNF treatment. Additionally, these agents should not be prescribed in the presence of active infections like respiratory tract infection in someone who has fever, non-healed skin ulcers, or life-threatening fungal infections or herpes zoster infections. So now comes the question of fever, whether it is because of infection or because of disease flare. So obviously, the basic steps one has to follow: history, clinical examination to find the focus, and investigations. And now we are going to look at the value of inflammatory markers in allowing you to differentiate between infection and disease flare. So there are many molecules or markers which signify both inflammation and infection. And traditionally, the markers have been ESR and leukocytosis with left chip. But both ESR and leukocytosis just signify inflammation, which may be due to disease activity itself or may be due to infection. Then there are acute phase proteins like CRP. Again, it suggests both inflammation and infection, but it is also a marker of response to treatment, and in that sense it has a value. And determination of C-reactive protein is useful in diagnosing infection or supporting evidence of infection in any sort of acute or ongoing inflammation, and for evaluation of metabolic risk.